started.
9 o'clock. I think it's time to start. Hello, everyone. Good evening. Welcome in the winter session of GC Orthodontics webinar. And today it's an honor and a privilege because it's also a friend. I have the pleasure to introduce to all of you Dr. Christian Samolia. Just for your information, it's a great a webinar because we will be around 800 registration tonight. So it's I think the topic is really looking for all of you. And so thank you, Christian, to accept this invitation. And just a short summary of what are we going to talk about. Of course, the topic is mini implants and clinical reality versus marketing fairy tales. So we are very excited to see what you are going to present. And also today we have, as usual, the chance to have Dr. Stefano Troiani as the moderator of this evening, and not also moderator, but also a great speaker that most of you know. And for 45 minutes, Christian will give us a better understanding what to do or not to do with mini screws. So, Stefano, it's
Thank
for
you,
you.
Jack. And good evening, everybody, wherever you are. Chances are you are buried under snow, like half of Europe. And so it's a beautiful occasion to be all together tonight in the warmth and to listen to Christian. Christian is a colleague, is an orthodontist from Timișoara in Romania, and is a friend, is one of the group of speakers that we try to be together and to bring a message together. And our message, as you know, is try to be honest as much as possible. And nowadays, the impression that not only us, but a lot of colleagues have is that in the orthodontic world, this is becoming really a rift between who tries to give a message that is more or less correspondent to reality and who is conditioned only and exclusively by the need to sell material or to sell himself or herself. And that's where it comes also the title of the presentation of today, the use of mini implants. The use of mini implants is also something that you have to consider under this aspect, meaning that in presentation, it looks like there is never gingival hypertrophy. It looks that there is never screw failure. It looks like placing a screw in the halar ridge is the easiest thing of the world. Everything always runs fine on Facebooks and on presentations. Reality is not exactly like that. So what Christian will do will give you an honest approach and tell you really which are the expectations that you can have during your treatment. A practical information, when you have questions, please write them in the Q&A or in the chat, and at the end of the webinar, we will read them to Christian. And now, time to get to the topic, and therefore I leave the podium to Christian. And Christian, please enlighten us about TADS.
Thank you, Jacques. Thank you, Stefano. Thank you, GC, for inviting me. It's always honor and pleasure to spend time with you, and also thank you for all the people that are connected and are going to be part of this evening. Hope my screen is sharing. It's okay. Okay. So today I am going to speak about, as Stefano said, about what's happening with the TADs. But one of the most important thing to remember about the TADs is that we started using them quite a lot. And this means sometimes that patients can look like this. We need to think when we start using TADs, are we really need all those TADs? Can we do something without them? Over treatment is very, very often in our practice in latest days. So it is really good to think about if you're going to use a system, regardless what type of system, do we really need everything? Do we need like 15 TADs in a patient in order to treat the patient? So that is what we need to ask ourselves. Why do we need TADs? On the other hand, It's much more easier to work when you had TADs. Let's think about transverse dimensioning. If I want to expand and I'm going to apply a simple Hirex expander, I'm going to have unwanted results. So my teeth are going to tip. I'm going to have some problems, and I'm not going to get enough expansion. So one of the reasons is that we did not have enough anchorage on different teeth or tooth in order to get the movement that we want as we want it. So this is one of the reasons why to use TADs. Also, we can use, for example, non-compliance appliance for different situations, because many times we say, okay, we need TADs because our patient is not cooperant, and that's true. TADs are really helping us to get better results without patient cooperation. But then again, when you use non-compliance appliance, also you will have side effects. For example, for herpes appliance, you're going to have lower incisor proclination. So in this situation, also you can use some TADs in order to benefit from better anchorage. And there were studies done where mini screws or TADs were used in order to control the secondary effects, the unwanted effects of, for example, herpes appliance. So what are really TADs? We are using TADs every day, and they're really a temporary anchorage devices. So there are some mini screws or mini implants or micro implants. There's a lot of names for them, but the most important thing to remember is that we're going to use those TADs for a limited time in the mouth. We are going to apply them, and if we are lucky, we are going to have, not only lucky, but if you know what we do, and we are going to have them for a longer time in the mouth in order to finish our treatment and get the results that we want. And in order to get those results, we're going to need to use them. So as I was saying, there are multiple reasons to use TADs. Among them, Nanda is saying that difficulty in obtaining compliance, it's one of the reasons, and growing number of adult patients also, because if you don't have enough anchorage teeth to use, then you will need to use some TADs in order to apply a mechanic that you need in order to get the result that you want. So in order to have success with TADs, you really need to be very careful about few things. Amongst them is the design of the TAD, and we will discuss about every aspect in part. Then you need to be careful about the bone quality. You need to be careful about insertion technique, and you need to be careful about tip moment. When something of these, one point of these, is not as it should be, or we are not very good with it, then we are going to have some problems using TADs. About the design of the TADs, we need to know that most of the TADs are made either of titanium alloy or stainless steel, and most of them are smooth, but there are also TADs that have etched surface in order to get some kind of, let's say, osteo integration, early osteo integration. But mostly all TADs have good stability, regardless if they are titanium or stainless steel TADs. Also, we need to know that there are two different types. There are self-drilling and pre-drilling systems. And for the self-drilling system, it's important to have a very sharp point and tip. And it's good to have a tapered shape of the TAD, regardless of the system, because it's going to give us more resistance in the neck area in order to prevent breakage of the TADs. Then the thread design can be pretty much important. There are some studies done, and we can use this thread design to get better stability. It is really important when we insert the TAD to have as much as possible contact with the bone. And then we have the different head design. And when we are using TADs, if we choose like a bracket head situation where we have a lot of mucosa around and it's a bad hygiene and we like it, a bracket head may not be maybe the best option. So it's good to have different options in your office. So if you have a simple head TAD, it's going to be very good for elastics, for example. Maybe you need it with a TAD with a hole in the head, so you can apply some ligature wire on that, or you really need bracket head in order to apply some more complex mechanics on that TAD. On the other hand, pre-drilling TADs need a drill. For that, we need a surgical engine or an E-driver. And what is happening there, the contact of the TAD with the bone is a little bit reduced. Now, when we are drilling, it's important to remember that we are not going to use the same size, the same diameter of the drill as a TAD. Usually it's around 0.5 smaller diameter of the drill than of the TAD. Also, the size of the TAD really matters. Now, guys, I know, but size does matter. And the studies are showing that if we are going to use 1.8 millimeter diameter and we are going to use like 6 millimeters of thread length, we are going to have very good stability. And you know what? Above these values, the stability is not going to increase significantly. So if you get to these values, it's quite enough for orthodontic treatment. But you need to remember, if you're going to use smaller TADs, either smaller diameter, either smaller length, you're going to get less stability. So think about the situation when you have, you do not have that much space between two roots and you need to use like 1.5 millimeter TADs or even smaller maybe. I don't like smaller TADs. Then you need to increase the length of the thread. So you need a longer TAD. Also, it is really important to remember to have TADs with different length of the smooth neck of the TAD. Because if we have thick mucosa and we are going to use a TAD that has threads all the way to the head of the TAD, a part of mucosa is going to be on the threads, and there is greater risk of inflammation, hyperplasia, and infection. And as a result, we're going to lose that TAD. Also, we can use our TADs from sterile packaging or non-sterile packages. So this is really the choice. And for example, when we have a situation and we went with the TAD too much into the mucosa and we have our TAD with the thread, in this situation, I just forgot to put one. I thought that mucosa is going to be thinner. I did not measure it properly. Usually you need to measure, take a perio probe and measure the depth of mucosa. It's the easiest way to do it, but I've done a mistake, and you can see the result. My TAD, it's covered with mucosa. This happens if you're not careful. Also, it can happen if you tighten the TAD very much and your head starts pressing onto the mucosa, then you will get hyperplasia of mucosa and it's going to get cover over the TAD. Okay, in design, features related to the devices, most problem are by fractures if you are using too small diameter of the TAD. And if there is a high density of the bone and a small diameter of the TAD, it is going to provoke fracture of the TAD around the neck. It is good to know. I just came from Germany, from Traben-Trabach, from a meeting, and there was a very interesting presentation. And the conclusion was that if you're going to stop and go and stop and go, every time when you start screwing the TAD again, you need higher force, and just after it starts going in, then force goes to a plateau. So it's good to avoid stop and go, stop and go. Just do it from one single stress. Solution, if you have breakage, is to, of course, remove the broken part and to choose another spot, another position for the TAD, and choose a TAD that is going to be with the solid neck, so a little bit more conical shape. Also, infection around the screw is, again, as I have shown you in the photo, can appear around the screw, so we need to choose the variable length for that. Now, the bone quality. This is a very old study, and the conclusion of this study that a good area to apply TADs is around between first molar and second premolar. So that's a very good area in the upper. But now we have CBCT, and it's much more easier. So if we are going to look for a space where there is enough bone to look at the bone density, the easiest way is to do a CBCT. I know not all the way around the world it's possible to do CBCT whenever you want. I am very lucky because in my country I can do CBCT when I need it, and it's much more easier to decide where to place TADs, or even you can use digital guide, so print a surgical guide in order to place the TAD exactly in the position that you want to be. Now, later studies done on CBCT are showing us the same idea, that there is the best area to apply the TAD is between first molar and the second premolar, and that's valid for the palatal posterior supraalveolar area. So in the same area we can use for palatal TADs, and also if we are thinking about the palatal TADs, there is the T-zone that is behind the third ruga, around 2 millimeter behind the third ruga, and also paramedian around 4 millimeter. There is a good area for insertion of TADs because there is enough thickness of the bone, and the thickness of the mucosa is not that high. So I suggest these areas, and then make the appliance or biomechanics in order in such a way that you are going to get the result that you want. Also, distance to alveolar crestal bone is critical. So if you apply a TAD higher, the probability of better stability gets higher, but we need to be very careful because there is mobile mucosa. And in situation when you apply a TAD into a mobile mucosa, there is a risk of mobile mucosa coming over the TAD, overlapping, or even losing the TAD. So we can see in this situation, we have mucosa over the TAD, so only the elastic chain is now out of it. So this is not very pleasant, neither for patient or if you need to do an activation. Even if the TAD is stable there, when you need to do an activation, change that elastic, it's not really comfortable. It's really hard to do it. So it's good to avoid this type of situations. One very important thing that I also seen in my office, it is TADs used in children. So when you have like 12-year, 13-year-old kid and you want to use the TAD, I observed that there is a greater loss of stability of the TADs in that age. And this study is showing that the greater the age, the older the patient is, the better stability is. And it's logical, on the other hand, because there is the maturation of the bone. And I am expecting more and more articles to see about this, because I think it's very important to understand that when you have kids, you cannot always expect to have a very good stability in TADs. And the rate that we are discussing that the TADs are very good, have pretty good stability, is getting drastically lower in this situation. Failure related to patient, to the bone quality, is when the cortical thickness is really low. So we need to think about other area to apply, or to think maybe about indirect biomechanic in order to get better situation. less force onto the TAD. Also, patients with thick mucosa, we need to think that we need to have a longer, smooth neck, but also we need to think very careful about the length of the TAD, because you will see later there is a big moment created in this situation when we apply the force on the TAD. Bone remodeling, when we have extraction or there is a deciduous tooth, is going to provoke also loss of stability of the TAD, so we need to be careful about that. And then there are situations when you cannot do anything and you need to accept that that patient, you cannot use temporary anchorage devices. Now, it is easy until it's not. Insertion technique. Insertion technique for TAD is really easy. It's not that complicated. It's like putting a screw into the wall. You just need to keep it steady, not wiggle with the screwdriver. It doesn't matter if you're using manual driver or e-driver. You need to keep it steady. You don't want to wiggle, because that is going to provoke early loss of stability. And it is really important to have low force. For example, for buccal TADs, when I use buccal TADs, you don't need more than 15 Newton for torque moment. It's quite enough. Usually you don't need even 15, and the TADs are going very nicely. On the palatal, I usually use around 25. But what is to remember is that when you apply more force, when you feel more resistance, you should stop and think what is happening. Now, different systems have different options also of how its stability of the TAD on the driver. And when you have a problem that you want to take off the driver after you've put the mini implant, the TAD, into the bone, and you want to take off the driver, and there is a big resistance, please don't wiggle, don't try to put it out. The easiest way is to take off the e-driver from the driver, or the handle out of the hex, out of the driver of the screwdriver, and then with the fingers very nicely try to take it out. If you're going just to pull, there is a big probability that you're going to lose that very, very rapidly. Again, insertion technique, angle of the TAD. In my office, I usually use around 19 to 45 degrees angle of the inclination of the TAD regarding to the perpendicular of the occlusal plane. But there are different studies that say that 19 to 45 degrees angle is good. And I recommend 45 degrees when you don't have enough space, because as higher you go, there is more space between the roots. So the risk to touch the roots, it's getting smaller, and the bone around the TAD is higher, it's more. There is another study that shows, for example, that for jail and storm, it's 19 degrees. Very good for stability, but then for the thunder TADs, it's like 15 degrees. So it can vary from one producer to the other. I think that's remaining between 19 to 45 degrees. It's a pretty good angle, and it's really easy to apply in everyday use. Another thing that we need to take care about is the space between the roots. If we are too close to the root, what is going to happen? It is that we are going either to touch the root, either to touch periodontal ligament. Now, I am using only a few drops on anesthesia when I'm inserting a TAD, and this is the reason for this is to patient to feel pain when you get close to the periodontal ligament. If you're too close to periodontal ligament and there is not too much anesthesia, the patient will feel pain, and then you know there is a problem. You don't go any further. Also, if you are touching periodontal ligament, most probably you're going to lose that TAD very, very fast, because it's going to also touch the TAD and is going to produce inflammation in that area. The distance between the TED and the root in ideal situations should be around 1.6 millimeters in the maxilla, 1.3 millimeters in the mandible, but sometimes there is not that much space, sometimes there is less, and in this study you will see that if there is less, there is a bigger probability to lose the stability of the TED. Now, as I was saying, if you feel greater resistance, it doesn't matter. If you go with the hand driver, you will feel resistance. And just remember, if you go with the hand driver, with the hand, you apply a lot of force, much more force than you would apply with the e-driver. So if you have a hand driver, you will feel the resistance and then just stop. Don't just go more. Stop, retract, find another position for the TEDs, and then reinsert that. If you are with the e-driver, it's really easy to see when you have more resistance. You will hear the e-driver going differently, but also you will see on the screen, the small screen of the e-driver is showing you increasing value of the torque. So if you see that the torque is getting higher or your e-driver is stopped, that means that most probably you're not anymore in the bone. Most probably you are somewhere touching a root of a tooth. And this is my case. And sadly, you can see very nicely this hole here. This is not for me, but this is for me. I made that hole in the root, sadly. I made too much anesthesia. I've done it only with the OPG, and it would have been better if I have done CBCT before, not after, and decide a better position of the TED from the beginning. So yes, this could happen, and I felt a lot of force, and I say, well, I think it's okay. And I just went over. It's not okay. When you feel the force, please try not to do what I have done. On the other side, we are lucky because even if we touch a root and we remove the TED, in 8 weeks, we can observe the healing cementum on the root. So reparation is going to appear and is going to help us not to lose the tooth. Also, if we are going to press too much the TED into the gingival area, so if we are going to screw it in too much and the head is pressing the mucosa, you will see this kind of effect that mucosa is going to come a little bit over the TED. Failure related to operator is the fracture of the cutting tip, especially when you start insertion. Do not press very hard on the TED because the tip is very fine, and if you fracture the tip, the TED is not going to advance, so it's just going to spin in that area and it's going to produce a lesion on the bone, but it's not going to advance as we want. So please do not push very hard. Start with a light force, maintain it, and then you will feel at that moment that the screw is just pulling inside the bone. It's just going in. You will just feel that. Okay, another problem, the screw when you tighten excessively. So when the smooth neck is going into the bone, you should stop, because also if you get with the smooth part into the cortical area, you will lose that thread that is going to maintain better stability. So you're going to lose really stability of the TED. Okay, so when you feel resistance, please be careful and stop. Then when you have bracket head, be careful about the ligatures. And as I was saying, the wiggling, we need to be very careful about that, not to wiggle in order to get better stability. Risk for infection, it seems to be higher when you use flap surgery. It is the conclusion of the Ravi Nanda, and we need to take into account that also. Another important issue of the TADs is the tip moment. When you have a TAD and you have a thick mucosa and you apply a force, the center of resistance of the TAD is going to be further away. So we're going to create a greater moment. So this way we're going to to apply more force, and then we're going to use the TAD, to lose the TAD. On the other hand, if we have thinner mucosa, the center of resistance of the TAD is going to be closer to the head, so the force is not, the applied force is not going to create that much moment. So we need to take care about that. So if we have thick mucosa, as I was saying earlier, we are going to need a smooth neck, but then we're also going to need a longer thread. So if I'm going to use in this situation within mucosa like 6 millimeters, in the other one I will use most probably 8 millimeters. Another option, when you have too much moment, when you think you do not have enough quality of the bone, you can use indirect anchorage. Indirect anchorage is very easy because it's not going to apply so much force on the TAD, and we are going to apply the force to the tooth and stabilize the tooth by the TAD. But we need to remember that this situation, it's not absolute anchorage for this tooth. This tooth is going to easily go to mesial and easily tip mesial. It's normal because it's not absolute anchorage, and the distance of the this arm, this power arm, is from the TAD and from the tooth is bigger, so that is why. In order to avoid very big moment, we should use less than 900 centinewtons forces when loading the TADs, so we should have better stability. All the studies are showing that failure risk with the TADs is around 10 to 15%, which is pretty good. The best failure rate, it is for the palatal TADs, where the palatal TAD inserted in the T area have the best results, and the risk of the losing these TADs is really, really low. Now, I'm going to go through different situations. Usually when I think about the case, I think it in different dimensions. So I'm going to show some different approaches for different dimensions. We're going to go through the transverse dimension, then go to the vertical, and then to the sagittal dimension. I will show you different options, how you can use TADs, but there are so many others. In orthodontics, our imagination is the limit. Now, for the transverse dimension, of course, the palatal area is the best area to apply TADs, because there is where we want to have the appliance also, but also there is where we have the most bone. And there's a lot of studies, and usually this T-zone, T area is very good. So distal to the third palatal ruga and paramedian, it's a good area to apply TADs. Now, in my office, I use quite often MSC appliance, but MSC appliance, it's appliance-driven system. What does this mean? This means that I put my MSC appliance, my expander, I put it where I have the most resistance, in line with zygomatic butters. But in that line, if you look at the T-zone, there is not so much bone. So I will need to apply somehow my TADs in that way to have more anchorage. And in this situation, I usually look for bicortical anchorage. You need to have bicortical anchorage, and bicortical anchorage means that you have at least the tip of the TAD into the second cortica, into the nasal cortica. Now, if you do not respect this, and you're not paramedian completely, and look, you can see here, there is a distance between the tip of the TAD and the second cortica. There is a huge, huge chance that you're not going to achieve expansion. And here you can see the tipping of the TADs, and that's the clear sign that you are losing anchorage and that there is no expansion. In this situation, for sure, there is not going to be any expansion. Okay, now this is a completely different situation. Here I have two corticals, not very thick, but it's true. You can see it here. We can see very nice parallel expansion. This is why I love this type of appliance. But you need to remember, at least 2 millimeter. When I have 2 millimeter of cortica, I am a little bit like, should I try something different? I love to have around 3 millimeter. Around 3 millimeter gets really, really nice. So you always need to have bicortical anchorage in this type of situation. And I'm just going to show you this case very fast. I'm not going to go through all case. You can see I got expansion. You can see here the diastema. But then if you look at this molar, you can see, okay, something's happening, something's awkward, something's wrong here. So I tried to bend this arm in order not to push my molar out. And at the end, I just cut them out and I got the expansion. I did not get the amount that I planned to because I lost the anchorage, but the expansion is okay. I wanted to have more. I got only 6 millimeter of expansion and I could finish with this with a nice situation at the end of the treatment. So not everything seems exactly as it is. Oh, you just put the TADs and it's going to work. No, we need to be careful what we are doing, and not always the predicted results are the results that we are going to get at the end of the treatment. And there is an article published in 2023, so it's a pretty fresh article. And in this article, you can see that they are discussing if there is enough options of the TADs for the situation of prefabricated, so appliance first, as I was showing earlier. And I can tell you that I'm doing something very different. Now I'm always using digital planning. So I use STL of the scan and I use STL, I use the CBCT, and now I can be sure that my TADs are long enough in order to get bicortical anchorage. And this you need to transfer into the office. So I usually use also printing, and this is what goes to the lab. So lab can produce me the TAD, the system, in order to apply it later into the mouth. So this is how it looks in order to get better solution. Nowadays, digital solution are giving us the possibility to make it easier for us. For the beginning, when you have less experience and it's hard to work with TADs, I recommend to get a lab or to get the software and start doing digital planning, even for buccal, even more for buccal TADs. You know, I think buccal TADs, position of the buccal TAD is harder than the palatal TADs. So you can use digital planning and you can use surgical guide, and you can almost do it with that blindfolded. But when you're doing directly, you need to be very careful about all the topic, about all the points that we discussed earlier. Now, look at this situation. Here I have a very, very nice bicortical anchorage. And I said, okay, we are going to get really nice expansion. But you can already see here that there is tipping, even though this is a male adult patient. It's not really going the way we want. You can see bicortical anchorage. This was digitally planned. Everything should work like perfectly. But then you see the angulation of the TADs. And it's get clear. This is not going to go only by TADs. So I decided to send that patient to the surgery and get SARPE, surgically assisted rapid palatal expansion, but with the M within. So it's SARME. Okay. Now, as I was saying, not everything gets really nice. And this is a case of mine from the last year, because it was a little bit past this time of year. It was holidays, and I applied the, I'm not going to do this anymore. I'm not going to apply expanders before holidays. I applied the expander, I give the key to the patient, I said, okay, you just turn the key and it's going to be okay. And she called me at one moment and she said, you know, I have a little bit of gingiva over my expander. I said, don't worry about it. Just rinse it really good, clean it really good. It's going to be okay. And this is after holidays. So it was horrible. I don't want to see this in my office. So when you're doing with the expander base, please be careful about the position of the TADs and about the forces that you applied. Now, there's different systems, bone-driven systems. For example, MAPA protocol or PSM, or in this situation, MAPA is looking for necessity, recommends it. It's looking for 3 cortical anchorage. And I will show you this case very fast. This is a planning before. This was not situation for 3 cortical anchorage, but you can see how the planning is doing. Also digital, you get the transfers, surgical guide, and everything goes really nice. So also I had a situation like this, but not everything went really nice. I do not have photos from that case, but it was really hard to apply the expander. The TADs were not in such a good position. Sometimes happens. So we need to be also careful when we decide what system we're going to use. We need to be also comfortable with it. On the vertical side, we can use the same expander sometimes for the vertical, but you can use different system with 1, 2, or palatal TADs, buccal, in order to get the intrusion. I'm not going to stay very much on this. We're going to do, for example, we want to do intrusion in the frontal area. We can do 1 TAD and do intrusion. In this case, I wanted to have some proclination, so I decided to go with only 1 central TAD. In these situations, be very careful about the frenulum. If you're going to be into frenulum, that goes a lot of inflammation. It's very uncomfortable for the patient. It's not going to be a nice situation for your office. So after you do the leveling in this situation, I used another TAD in order to control a little bit more the canting of the occlusal plane. And then remember, we're collaborating with our implantologists, with our prosthodontics. When you can use a dental implant, it is the perfect anchorage. You have a lot of anchorage on dental implant. Just ask your implantologist or dentist if you can use its implant for your own purposes. So I'm not going to stay with this case too much. Next case, we can use multiple TADs. For example, this patient came to my office. She wanted treatment, and I started classically. It was okay, let's use some utility arches and then work with it. But she went out of the country. She said she's going to find an orthodontist, and 1.5 years later, she came back looking like this. So I decided to start with the TADs. And in order to get in the same time intrusion and distal movement, I applied the TADs. But here, can you see this? So as I was saying, not always things goes nicely. You have inflammation. This TAD could get mobilized in this situation, so be very careful. Also, here you can see the same, but in the upper jaw, you can see that we get a really nice distal movement and in the same time intrusion. Also, you need to use very stiff wires in situation when you use TADs like this, because the wire is getting deformed if you apply the forces onto the wire. When you're working in the posterior area, you need to be very careful about where you're applying the force. If you want bodily intrusion, usually this is the most problem. When you want to do intrusion of the molars, you want to have bodily. If you just apply 1 TAD, you're going to get some tipping. Either it's going to be buccal, either it's going to be palatal tipping, is because you're applying force only on one side of the tooth. So then either you apply 2 TADs, either you apply something like TPA and 1 TAD on each side. You need to decide what you want to do. And this is a situation where I decided to apply TAD. Usually when you apply TAD like this, 1 buccal, 1 palatal, you just go with the elastic chain over and it is nice. But sometimes patients, while brushing, if you do not stabilize, or there is no possibility to stabilize this elastic chain, it slips sometimes and it can cut really, really hard into the gingiva between 2 teeth. So be careful about that. Also, we can use TADs for upright of the molars. This is an option with the upright cantilever. And you can see how nicely you can get the results. But if you look a little bit more careful, you will see here I got a little bit more palatal tipping, even though I had initially covered over the occlusal area. So I decided to go with the buttons in this situation and to apply only buccal force at one moment to get a little bit more buccal tipping. This is another situation where I really recommend to use TADS. Now I have occlusal plane straight till here, and then I have over-erupted first quadrant. In this type of situations, it's really important not to bind the good with the bad, as Birte Melton saying. So I decided to do intrusion on TADS, and you can see here a web of elastic chain. And just after I have done the intrusion, I can go and bond everything else. Otherwise, we would have deformed the occlusal plane, and you are using the TADS, but if you are using it too late or too early, it might not be of help, or it might get you even more complicated. So you have to be careful also about the timing where to use the TADS. And these are the steps going through the case, preparing for prosto. My prosto is very demanding, so he sent me this. He said, change these. I don't like these inclinations. So this is the end of the treatment, pre-prosto. This is after prosthodontic treatment. So in order to get nice results, you really need to be very careful about planning. Also, vertical dimension, we can use, for example, mousetrap. I'm not going to go through all the case. Important thing for this case, it was that we needed to do intrusion and maintain the vertical dimension, because the face of the patient was not allowing us to do more rotation. And also in the anterior area, you can see there is no enough vertical, so we needed to do intrusion. I started with the mousetrap, so you can use palatal TADS, and then added brackets, added composite. When you're doing intrusion, don't forget about occlusion. What is going to happen? You're intruding upper side, but in the same time, maybe you're going to get extrusion in the lower. There are two options. Either you put some bite tracers in the posterior area, bite blocks. Either you're going to apply some TADS in the posterior and lock in vertical dimension posterior teeth in order not to get over eruption from the lower arch. Okay, so going through the case, you just prepare the case, and then you can nicely finish the case with the mock-up and with very good, stable, and functional occlusion. Now, when you have a case that's asymmetric, this was an asymmetric case, and sometimes patients don't want to solve everything. They just want to have a little bit better smile and to put an implant here and an implant here and here. And that was the patient demand. If we look at the OPG, we can see the tipping here, over eruption here, and the tipping of this molar. So the decision was to do segmental treatment, and this is an option to do it. So if you use palatal TADS, now I would recommend for adult patients always, and for young patients, always paramedian TADS, not in the medial suture. But I use this at that moment, and you can see I had a way to go over and then apply force from the buccal, but also from the palatal side to get intrusion and distal movement. And in this situation, you can see an indirect anchorage. So when you're using TADS, also you can use indirect anchorage. You have these two premolars in the indirect anchorage. When I use indirect anchorage, I usually use composite over the arch wire. I don't try to put ligatures, because they can also provoke lesions and inflammation of the area. So this is the way you can obtain good results, even if you're not doing full arch treatment. And with this, my colleagues could finish the case very nicely, even though at the end, the midline is going to be shifted. The patient was happy, and the end result is very, very nice. And what is most important, it's still functional result. It's not only aesthetic result. On the other side, we have the sagittal dimension, and in sagittal dimension, this is one case of mine that I decided, okay, I'm going to go with pendulum appliance. And then I applied pendulum, and after I got the distal movement of the molars, I saw that my molars are a little bit tipped to the distal, and I don't like that. And then I decided to apply 2 TADs on each side, one, and I decided to make this cantilever that is going to apply the force in such a way that it's going to give me not mesial tip, because my crown in this moment is blocked, but I'm going to get the distal tip of the root. So I'm going to upright my molar in the better position. So this was the idea. And then just after I do this, to use the same TADs for direct anchorage and to retract the whole, the all other teeth. And you can see that that works really nicely, but you need to be very careful about the TAD position, and you will see in a case later. So you can see in this situation, I have really nicely uprighted molars and really nice good position, so I could finish the case really good. But you need to respect all the steps. This is a case that wanted that the midline was a problem. She had earlier treatment and she is missing her canine, and she wanted to have midline in the correct position, but she did not want extraction. I said, okay, we are going to think about something, and I went with the option to distalize. Now, this is one very often situation that I use when I have relatively good alignment of the teeth. What I'm doing, I apply brackets, and then I apply a 20 by 20 bioactive wire, and I use the TAD as indirect anchorage. So I apply a ligature from the TAD to the canine, and then I put an open coil spring between the molar and canine, and I'm not ligating the premolars. And you can see very fast I got some distalization. I went with the canine into, this is 1 week later, it was just my fault. I did not close the clip. I saw it in the photo. So a week later, I called the patient and I just bonded afterwards the bracket. So I have my molar in the first class, and now I have here a stop that is going to prevent my molar coming back. And then from the TAD to the hook on the arch wire, I just apply elastic chain, and then my premolars are just going to align. Now, if you look at the TAD, you need to be very careful. Now, when I start pushing, when my premolar is getting to the distal, there is a huge risk that that premolar is going to touch the root, is going to touch the TAD. So you can see in the next image, I changed the position of the TAD, I put it more distally, and then I applied another force in order to finish the case. So you can get very good results, but when you're using buccal TADs for sagittal movement, you need to take into account that it is very possible that you're going to need to change the TAD position during treatment, because you're going to get your roots onto the TAD. And even if you did not put the TAD in the roots, when the root is start touching the TAD, it is a huge probability that that root is going to get damaged. And this is the end of the treatment. Another option to do distal movement, it is to use, I'm not going to go through all the details of the case, it's a more equilibrated case. It has just more crowding, but it has good lines. It doesn't have cunting. Its midline is good. So it was a pretty easy case. We need to extract some third molars. And then my treatment plan was no extraction. I will not go into that, but I needed to do a lot of IPR in the lower jaw, and I needed to do distalization on the upper. But I had pretty huge crowding, as you can see here. Now, you cannot go with 20 by 20 in this situation, especially if you do not have enough overbite, because there is a risk to open the bite in the same time. And you want to have low forces in the vertical dimension. So I decided to apply a power arm and the force from the power arm to the TAD in order to get the distalization first. So I applied the power arm into the second tube of the second slot of the molar tube, and then I apply the force from the TED to the power arm. And after I've done the stripping in the lower, you can see that I changed a little bit the design of the power arm. I make the arms a little bit lower, and I applied night eye closed coil, and I let the patients just to work through the stages. And you can see very nice distal movement of the molars, and in the same time aligning without proclining incisors. This works really beautiful, but there is one thing that you need to remember. Whenever you're applying force from the buccal side in this situation, you're going to rotate your first molar into correct position, and then it's going to get over-rotated. Every time that you over-rotate the first molar, the second molar is going to get pushed in. So there is a very big risk to get into the crossbite with the second, and afterwards, if you're not going to be careful, it's going to get into the crossbite with the first molar also. So please be careful about the transverse position also of the upper teeth, and go through the sequence of arches into the larger arch. After I achieved class 1, then I started working. This is the finishing before ending, and after debonding, we can see a little bit of spaces between the teeth because of the lateral peg-shaped laterals, and this is the end of the treatment with additive composite on the laterals. So we can use this system on the buccal, but we can also use system on the palatal area, and this is a situation of the class 2 patient when I decided to use from the palatal area to use a benefit system, Bennett slider. I just apply 2 TEDs and then I apply the forces. And you can get really nice distalization with this. There is not so much tipping or almost no tipping, and you can get really nice result. You have very good stability, but you need to be careful this area when you have this Bennett plate made, it has to be passive. When you apply the Bennett plate onto the TEDs, it has to be passive. If there is a tension, you're going to produce tension into TEDs, and then even here you can risk to lose the TED, so lose the stability of the TED because of the too much tension. Also, when you are using these palatal systems, you need to be careful about the created moment. And I'm just going to go to the finish of the patient. So this was the end. And what is important to remember, it is that when you apply forces from the palatal side, you're going to get closer to the center of resistance. That means that your molar are going to distal move better, so you're not going to get so much tipping or even no tipping. Even you can control with this system vertical, so you can intrude or extrude molars. But one thing that I don't like about this system is that either you're going to use very stiff arms and very stiff system in order not to get this moment, to control this moment. Either if you're using a softer system, you're going to get rotation of the molar in exactly the opposite direction that you want. So I don't like this. You can use Bana tube, for example, to get more control of that rotation, but always there is going to remain some problem. On the other hand, when you use buccal TADS systems and you apply force from the buccal, you're further from the center of resistance. That means that you need to control better. So afterwards, you need to the upright of the molars, but in the same time, you're derotating the molars into direction that you would really like to move it. But then, as I was saying, as you're going farther and farther with this, there is the risk to get too much rotation. Now, studies are showing that stability of mini screw for molar distalization is really good, so we can use it, and I'm using it for quite a long time. And yes, of course, sometimes you lose the TED, then you need to think, okay, where can I put another TED? What happened? Why did I lost it? Most probably when you go with the roots over the TED, that is the situation when it's going to happen when it's during treatment. If it's on the beginning of the treatment, it was the problem of insertion of the bone. There is the thing of the technique. Okay, so a lot of studies are showing that we can push the molars however we want. So there is a lot of stability, but we really need to think. And one of the most important things I always say is thinking in orthodontics. So just being able to do something that is not always the best way to do it. So when you're doing distal movement or when you're doing compensating, always look if there is bone when you are moving teeth. So there are different studies, but I like this one that is assessing posterior available space. When you're distalizing molars, you really need to know, okay, is there space to distalize? You cannot go with the molars like go distalize 5 millimeters every time. Sometimes there is, but usually you need to think about where you're putting the teeth. In the end, as a take-home message, I want to tell you to be careful when you're choosing the TEDs, to choose the type of the TED of the type of the system that you're using according to the patient particularity of the bone, of the system that you're going to use, about the mechanics that you're going to use, what movement you want to get. Then, when you're doing insertion, be careful about the insertion, about the position, about the articulation, about the wiggling. So if you're doing the steps correctly, and if you're in the beginning, I recommend you to choose a place where you know, for example, first molar, second premolar, it's a good area, and then start thinking about mechanics from there. And if you go, when you go more advanced, then you can start doing different location, maybe harder location. And also I recommend using digital system. Now we are in area of digital, we can prepare everything. We can almost do some things blindfolded lately. And one of the more important thing, choose your mechanics in regard with the case necessity. When you're applying that, think from the beginning the mechanics that you're going to use, how to use it in order to get the result that you really want. You can find me on my Instagram or on my email, and I would gladly answer even if there are later going to be some questions, no problem. But now I think it's time for Q&A. Thank you.
Sure. Thank you very much, Christian. Wonderful presentation, very nice cases. And I think it showed the point that at the very end of the day, it's our brain that counts. It's not so much which brand of screws or brackets or aligners we want to use. First question, what do you use for distalization in the lower jaw?
For distalization, the lower jaw, I apply between the first molar and premolar or between the two molars. And then afterwards, but in lower jaw, I don't use more than 1.5 millimeter distalization, rarely go to 2.
Very good. Next question for Dr. Raviglia. What age and gender limits do you set for hybrid expander, MARPE, or SARPE? What screw activation protocol do you do based on the patient's age?
It's not based on the patient age. So I look on the, if you know the McNamara study about the suture maturation. So I look at the suture maturation. When I decide to do expansion for the adult patients, and for example, for the male patients, in my practice, I saw that there is a very hard thing to get expansion in the male patient, adult male patients. So usually when I have very bony male patient, I just go with the SMARPE. So I apply expander on the TEDs, but I go with the surgically assisted. So it's not, you do not have to go nowadays with the floating maxilla surgery. It's quite enough to do reduced surgery in the area of the zygomatic buttress, and usually you get a very nice expansion.
Next question for Dr. Marton Soldos. Make some compliments, and then he asks you, may I ask what interradicular TAD are you using? What size do you use palatally?
Usually, hi Marton, nice to see you. We just parted ways a day ago, and yes, Usually I use 1.6 millimeter TADs and with the 8 millimeter screw, 8 millimeter length.
Perfect. If anybody else has got a question, write it down now, or otherwise you will have to reach Christian at his address that he left you, because I'm aware that it's late, especially in East Europe. And but if you've got any time for some more question, in the middle, I would just like to add a very small comment about the question about distalization in the lower jaw. I agree 100% with Christian that should be limited to 1 millimeter, maximum 1.5. And I want to emphasize one thing, that is one of the favorite Facebook Dontics treatment, huge distalization in the lower arch. But please think about one thing, all of you. The bone, alveolar bone, lingual to the lower incisor is about 1.4 millimeters. So when you see this distalization of the whole arch of like 3, 4, 5 millimeters, even if it was possible, where do you think the root of the lower incisor will be? So think about it. Don't get all impressed by occlusions. So Christian, another question from Dr. Joanna Colseiro Simon. Do you recommend extracting third molars before whole arch distalization in the upper jaw in adolescent patients?
Yes. Yes. It is much easier to do distalization if the third molar is extracted.
Very good. And okay, for now, it seems like there are no other questions. They will come for sure in your email address, so you will be able to answer them. And Christian, once again, thank you so much. It was a fantastic webinar, I think, very clear, very schematic, and very honest. So with this one, I say goodbye to everybody, and I'll see you all in spring for our spring session, when we will have another 3 webinars as usual. So good night and Merry Christmas and Happy New Year to everybody.
Thank you, everybody, and good night.
Bye.
Merry Christmas.